All right, so I'm going to talk about young adult hip pain. So as Dr. Oliver mentioned, I trained at Medical University of South Carolina in Charleston. And while I was there, I was doing a pediatric orthopedic rotation. And that surgeon happened to mention that a slightly crazy gentleman at Boston Children's Hospital named Dr. Mike Camillus was looking for a physician assistant, and he thought I was slightly crazy enough to be able to handle that position. So he called Boston, and sure enough, I got invited up for an interview, and I started my training there, and I was there for about 8 years. Now, when you're on the hip team at Boston Children's Hospital, you don't ever escape. So even though I've been at Plymouth Bay Orthopedics for 2 years, I am still associate clinical research staff at Boston Children's. And I still try and participate when I can, and that's allowed us locally at Plymouth Bay Orthopedics to have kind of a direct line there. So when we do have emergencies, I am able to call up there and get them in relatively quickly. So it's nice to have that resource at our fingertips. So I am going to talk about young adult hip pain, which is something that many of you guys see in your clinic. It can be a difficult situation to deal with, and there are several causes, which we'll go over. So who gets hip pain besides old people? So this is a quick list. In infants, we think about septic hip, toxic synovitis. In kids, an emergency is SCFE, or slip capillofemoral epiphysis. Toxic synovitis can also be present in kids, as well as a rare condition called Perthes disease, which is an idiopathic avascular necrosis of the hip. In teenagers, and now we're starting to see some of the kids we see in our local clinics, we see rectus femoris injuries, hamstring avulsion injuries, and femoroacetabular impingement, which I'm going to call FAI through most of the lecture. And young adults, which is our primary area of concern today, there's a whole plethora of conditions that can cause hip pain. We're going to go over a couple of those today, but I've got kind of an extensive list there. So common causes of young adult hip pain that we're going to talk about today are acetabular dysplasia, which is also DDH. Acetabular dysplasia is acetabular insufficiency. So it's when the hip socket is too shallow to contain the femoral head. This over time causes pain. Femoroacetabular impingement, which is when there's a mismatch in the shape between the socket and the ball, and that causes a pinching sensation. Psoas tendinitis, which is an inflammation of the psoas, which is one of the anterior hip flexors, and iliotibial band, which has been mentioned a little bit by Dave, which is also associated with the trochanteric bursitis. So the image here is a really interesting study that was done on ballet dancers, and they had the ballet dancers actually do a full-length MRI in the splits position. This showed that when the dancers do this, there's actually instability in the hip, and the hip is subluxing out of the joint when those dancers do that position. So next time you go to the Boston Ballet, you can think about the damage that is going on in some of those hips. So the pitfalls we're going to talk about are rare, but with my peds ortho background, I have to mention them. So slip capillofemoral epiphysis, Perthes or leg calvate Perthes disease, and avascular necrosis, also known as AVN. So acetabular dysplasia, so mild acetabular dysplasia typically does not become symptomatic until young adulthood. So in infants, we talk about Barlow and Ortolani tests where the hip is actually dislocating and relocating. In a kid who has mild dysplasia, you're not going to get a positive finding on those tests. And therefore, it may be missed unless there's a positive family history until the child is 18, 20, 22 years old, when they start presenting to us with lateral sided hip pain typically. So the lateral sided hip pain is from abductor fatigue, which is from a lateral insufficiency. In females, more anterior instability is seen, and patients present with anterior hip flexor fatigue or anterior insufficiency pain. So my pearl for dysplasia-related hip pain is that it's always activity-related pain. Dysplastics do not have pain with sitting. They complain of pain with running, with playing soccer. Sometimes they'll complain of a little bit of pain after the activity, but after they've rested for 24 hours, the pain typically gets better. I always get a standard set of images with patients I'm concerned about for acetabular dysplasia. I get a standing AP radiograph with the beam centered on the femoral heads. The centering on the femoral heads is important because it shows whether or not the pelvis is level, whether or not it's rotated. You can look for leg length discrepancies. I get a false profile view, and this shows anterior coverage of the hip. So this is a ballerina type view, so the foot is externally rotated and the beam goes across the front of the pelvis. A von Rosen view I typically don't get down here, but at least in Boston, this would simulate the coverage after periacetabular osteotomy, which is a surgical treatment for hip dysplasia. And MRI, locally we're changing the protocol a little bit, so we are starting to get an indirect arthrogram on the 3 Tesla magnet, which we're fortunate to have down here. If I am concerned that a patient needs a PAO, however, I would defer the MRI to let them do that in Boston, because they have what's called a degenerate protocol where they can actually measure the health of the acetabular cartilage and determine whether or not a patient is a candidate for periacetabular osteotomy. So for PAO depends on how severe it is. So the most severe patients have a lateral center edge angle of less than 16 degrees, and that's measured on the AP view. 100% of these will progress to osteoarthritis if it is not treated surgically. Lateral center edge angle of 16 to 20 degrees, the natural history is a little bit more clouded. So there's no good studies to show what will happen if you don't necessarily surgically treat those patients. Those patients typically become symptomatic later in age. And therefore, some of those patients will go on to have a PAO, and others will be told that, hey, you kind of have to wait out for a hip replacement, unfortunately. A lateral center edge angle greater than 20 is considered normal. However, in patients who have ligamentous laxity, such as Ehlers-Danlos syndrome, some of these patients will be symptomatic at the lower ranges of that as well. So this is a picture of a periacetabular osteotomy. So this is the surgical treatment for acetabular dysplasia. Let's see if I can figure out the pointer. All right, so we make 3 cuts around the acetabulum. There's 1 cut right here, there's a cut here, and that allows you to rotate the acetabulum over the femoral head to provide better coverage. As you can see, there are some pretty serious screws that go in there, and typically the patients have those removed 6 months to a year after surgery. So next we're going to talk about femoral acetabular impingement, or FAI. So the problem with this is that patients complain of pain with sitting for long periods of time. There was a conference I was at where actually the speaker looked in the front row and said, okay, I can count 5 people in the first row who likely have FAI, because they all sit, they're slouching, they're shifting position. So I'm not going to do that now and embarrass anybody, but 20% of the male Caucasian population has a bump associated with FAI. So patients constantly shifting, patients have pain with going from sitting to standing, and they complain of a pinching sensation in the front of the groin. So imaging for these, again, in a standing AP radiograph for the pelvis, there's a sign called the sagging rope sign, which is a sign of a fairly prominent bump on the front of the femoral head. I get a false profile view, which can show excessive anterior overcoverage, which is a sign of pincer type FAI. And on the AP, a lateral center edge angle of greater than 40 is usually pathognomonic for lateral overcoverage. We also get a view called a modified Dunn lateral, which our radiology department at PBO has been awesome about learning this year, so thank you guys. And this typically shows the cam lesion better than the traditional frog lateral. An alpha angle of greater than 60 degrees on the modified Dunn is pathognomonic for FAI. On pincer, you'll sometimes see a divot in the femoral neck, which is called a pincer trough, or impingement trough. So this is an example of a cam lesion. So you can see how the femoral head goes round, 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 and then there's this bulge right here. So if you can picture when the patient is in flexion, that bump can actually hit against the top of the socket right here. So on this patient, you can see some slightly increased sclerosis, which is that bright white, and you can also see there's blunting of the edge of the acetabulum, which indicates that there's been some impact over time. So treatment for FAI, physical therapy is always my first line. So if you can improve the biomechanics and stop the patient from impinging, then that's great. Next, I typically go to diagnostic injection, so Brett Turan has been great about getting our patients in for that. And if a patient has an intra-articular injection, which gets rid of 100% of the pain, then we know that A, the pain is coming from inside the joint, and B, the patient may be a good surgical candidate in the future. Finally, if surgery is indicated, that's an arthroscopic surgical debridement or osteoplasty, where we actually shave down that bump we see. I've included a picture of a hockey goalkeeper because they drop into a butterfly position. So hockey goalkeepers, martial artists, and softball and baseball catchers have higher rates of FAI that require surgery. On the USA bobsled team, the gold medalist team had a 50% rate of needing cam resections. So Steve Langton, from USA skiing, there's been several members who have also had this surgery, so it's very common in athletes. So snapping iliotibial band, I'll typically see teenagers who come in, they're ligamentously lax, and they come in and say, hey, I can pop my hip out of the socket. You cannot pop your hip out of the socket, let me reassure you. So I say, okay, show me. So they'll stand there and they'll kind of swing their hips to the side and you'll see their IT band popping over their greater trochanter, which is a pseudo-subluxation. This is commonly associated with trochanteric bursitis because kids will do it habitually, so they irritate their trochanteric bursa. Runners, cyclists, and other forward-plane athletes who hate cross-training, they have no lateral movement involved, they get a tight IT band, they can also have this. It may be a sign of a structural abnormality, so again, if a patient has lateral insufficiency associated with dysplasia, you can get some associated trochanteric bursitis or snapping IT band as well. So psoas tendinitis, patients complain of pain going up the stairs, not down the stairs, as well as difficulty getting out of a car because they're abducting and stretching that psoas. By the end of the day, they talk about having to lift their leg up, and they complain of popping in the medial groin, which sometimes they can reproduce. So for both psoas and iliotibial band treatment, physical therapy again is my first line, and we're super fortunate to have an awesome PT department upstairs, which helps out with a lot of our patients. Diagnostic injections typically are my second go-to, and surgery for this is really rare. Once upon a time, everybody used to release the psoas during arthroscopic hip surgery, and we found over the past decade that this leads to bad outcomes and patients are typically unhappy. You can do a lengthening of the iliotibial band. It's a small T-shaped incision over the trochanteric bursa, but that's pretty rare as well. And you can do a capsular repair or lysis of adhesions because you can actually get some psoas impingement in certain rare conditions. I haven't actually seen it locally. I saw a few cases in Boston, but it's pretty rare. So the clinical hip examination. So this is actually a picture from the dissection rooms at the University of Glasgow where I had the fortune of studying. It's a pretty cool place. So the purpose of the clinical hip exam is to correlate the patient's history and radiographs with objective physical exam findings. It helps you differentiate between intra and extra-articular hip pathology, and helps determine if the treatment best achieved by surgical intervention versus a more conservative treatment strategy. So in general, during the H&P I observe, I look at the patient's demeanor, I watch their sitting position to see if they're slouching or shifting position, I look to see if they can sit in one position for any length of time, and I ask the patient to point to the location of pain with one finger. My videos are playing now, but they're playing sideways. So ignore this. This is Emily. She was my nurse at Boston Children's Hospital. So I watched the patient rise from a seated position. Are they stiff or are they sore, which is an indication of possible impingement. I look at the level of the pelvis and the shoulders, and I look to see if the weight is evenly distributed over both legs, or if they're favoring one side versus the other. I have the patient do a standing Trendelenburg test, which if you were able to watch the sideways video is what Emily was demonstrating. And that's a sign of abductor function and abductor fatigue. And I look at the patient's general alignment. So this is a diagram showing a Trendelenburg gait where the contralateral hemipelvis drops with abductor fatigue or abductor weakness. So I watch the patient's gait next. I look to see if it's level, if it's antalgic, if there's any sign of an abductor lurch, and if the patient relies on assisted devices or equipment. Next, I do a supine examination. So again, I'm sorry, I don't know why my videos are sideways, but I do a log roll. So I look at passive internal and external rotation with the hip in extension. Next, I do straight flexion of the hip and watch for contralateral pelvic tilt. So patients always say, I can flex my hip further than that, but if the pelvis is engaging, that's the end of the natural range of motion. I look for pains at extremes of flexion, which may indicate ASIS impingement, or it may be increased with hip dysplasia. Next, I do internal rotation in flexion. This is limited in patients with femoral-acetabular impingement, with SCFE or slip capital femoral epiphysis, and with Perthes disease. The patients often guard as they anticipate that this will be painful. Patients with a lot of internal rotation typically have femoral anteversion, so a lot of our female patients. External rotation and flexion, this is painful in patients with psoas irritation. It's increased in patients with femoral retroversion, meaning their femur is tipped backwards. And if they have posterior pain, it may indicate a trochanteric impingement, which again is rare. I've seen a couple cases, but not something we typically see. Next, we do an anterior apprehension test, which if you can turn your head sideways, this is actually an interesting test. So patients with anterior instability feel like their hip will actually dislocate out of the socket. So you scooch them over to the side of the bed, you put the hip into full extension, and you externally rotate. The patients may feel that their hip is going to pop out, and often they will grab the front of their hip and guard against this test. Anterior impingement test, most of you guys are familiar with. This is flexion, internal rotation, and adduction across the midline of the body. Pain indicates a possible labral or intra-articular pathology. And provocative psoas maneuvers. So I have a patient raise an externally rotated leg against gravity and resistance, and this can cause pain. I also do flexion, abduction, external rotation, and extension. So I essentially stretch the psoas over the front of the joint, and you can get a psoas clunk. If there's inflammation, patients will have pain with this maneuver. And you do a psoas stretch test where the leg is extended off the side of the table and internally rotated. A Stinchfield test, the patient straight leg raises their leg against resistance. And this is painful with femoral neck fractures, as well as a soft femoral head, such as with avascular necrosis, or a rectus femoris strain. Abduction is limited with large cam deformities, femoral head asphericity, and a high right and greater trochanter. Lateral pain may indicate a trochanteric impingement. And adduction, I bring the leg across the midline, and normally is about 15 to 20 degrees. A Patrick test, the patient's leg is put in a figure of 4 position. The distance is measured between the exam table and the patient's knee. And if the patient has pain, it may be due to SI joint inflammation, psoas irritation, or impingement, depending on the pain location. These are areas commonly palpated. I don't palpate all these areas, but I do palpate over the greater trochanter, over the ASIS, which may be inflamed in a teenager with an iliac apophysitis, as well as posteriorly over the piriformis. Lateral exam, I palpate the greater trochanter for tenderness, which is a sign of trochanteric bursitis, and I test the abductor strength. So the key for this is patients try and cheat, so as most of our physical therapists know. So the key is to get them all the way over onto their lateral side to extend the hip and slightly bend the knee. That way you're really isolating the abductors. And we do a bicycle test. We have the patient actively move the hip from flexion to extension, palpating over the greater trochanter to feel for the iliotibial band snapping or popping. All right, so then I do a prone exam. So you look for internal and external rotation with the patient prone, just to get a feel for their natural range of motion, see whether or not they're anteverted or retroverted. And you can do an Ely test where you bend the leg at the knee to get the heel as close to the buttock as possible. And this tests for tightness or contracture of the rectus femoris. So my pros for the physical exam are to ask patients questions throughout the exam. If they're focusing on trying to answer your questions, it's harder for them to focus on guarding the hip against your exam. I always start on the asymptomatic side first to try and gain a little bit of trust. And I put the hip through the arc of range of motion to gently feel for subtle catching, grinding, or mechanical symptoms. Severely arthritic hips will have poor motion in all directions, and the arc of motion will not feel as smooth. So many patients will have concomitant intra and extra-articular pain generators, and it can be hard to differentiate which is causing the most problematic symptoms. Radiographic abnormalities do not always require surgical intervention. Not all bumps are symptomatic. So as I previously mentioned, 20% of the male Caucasian population has a bump on their femur. And the reason we know this is because in Switzerland, they have mandatory military service. So they're able to follow an entire group of 20-year-old men for about 2 years and get images that we wouldn't be able to do that type of study in America. Dysplastics typically have better than average range of motion with activity-related pain, and they may be ligamentously lax, such as gymnasts, cheerleaders, and dancers. And impingers, as we previously mentioned, typically cannot sit in one position for long periods of time due to pain. They have pain with squats, lunges, and often describe symptoms as always feeling tight despite lots of stretching. Many of them have been misdiagnosed with a groin strain at some point. So pitfalls. So this is my peds orthopedic PSA. So in pediatric patients who come in with knee pain, always check the hip range of motion. So pediatric hip pain often refers down to the knee, and a quick test is internal rotation. So if you flex the hip and internal rotate and there's limits, that's when you need to start talking about imaging. So I get an AP and a frog for all kiddos I'm concerned about with limited internal rotation. Kids with prolonged high-dose steroids, such as kids who have had ALL, be concerned about avascular necrosis in the hip. It is something that we fairly typically saw at Children's Hospital. And a sudden onset of limp, think Perthes, toxic synovitis, and septic hip, and refer for the appropriate workup. So this is a picture of typically what we see with slip capital femoral epiphysis. I'm embarrassed to mention that on my references, I did not include my own paper that I wrote. It's called the Skinny Skiffy, so you guys should all look it up. And what we found is that actually in New England, we did a study comparing patients against kids at Children's Hospital Atlanta and Children's Hospital LA. And we found that in New England, kids who get skiffies actually have lower BMI, so they are not the overweight sedentary kiddo that in the rest of the country they're seeing. And we're not quite sure why. So the second phase of the study is being conducted right now at Vanderbilt University, looking at vitamin D levels. But just remember, kids in New England have lower BMIs, and they're typically more active, and they're still getting this condition. So just keep it on your radar screen. But what a slip capital femoral epiphysis is displacement of the femoral head due to disruption of the growth plate. And again, there's still a lot of research being conducted on this. I am the co-creator of the largest database of skiffies in the United States right now, which is pretty cool, and they're still using that database. What they're looking at is length of diagnosis, was it misdiagnosed, how many screws were put across the physis, and various measurements to look at severity. Kids present with a painful limp with referred pain to the thigh or the knee. So again, this knee pain, so check the hips. And again, most commonly seen in adolescent obese males, but in New England, we're seeing skinnier kids come in with skiffies. The treatment for this is emergent. It's a percutaneous skin screw fixation. And the sooner you do this before there's an excessive slip, the better the kids do over time. The epiphysis typically slips posteriorly and inferiorly, which, if you can imagine, that's a really hard position to have your hip in later. You have it pinned in whatever position it ends up, and there is a new procedure where you can kind of reduce the femoral head, but it's very risky, and there's a fairly high risk of avascular necrosis. So in fact, at Boston Children's, there's only 3 surgeons right now currently certified to do that surgery. So these are my references. Again, Google the skinny skiffy because it's an awesome paper and you guys should all read it. These are the rest of my references, however. And thank you very much. And I'm a joint preservation guru, so this is what we're trying to prevent is the hip replacement. So no offense to Dr. Oliver and Dr. Zabilski. Thanks.